Human movement relies on a dual control mechanism. Electrical signals must traverse a precarious pathway from the brain down to the muscle tissue. A clinical motor exam is a systematic interrogation of this neurological pathway, designed to pinpoint exactly where the wiring has failed. The first half of this pathway is governed by the upper motor neuron, or UMN. This is the primary regulator of the central nervous system. This diagram illustrates the origin of the upper motor neuron in the cerebral cortex. It serves a dual purpose, initiating voluntary movement while continuously inhibiting the automatic reflexes in the spinal segments below it. From the cortex, the corticospinal tract descends deep into the brain, funneling through the midbrain toward the spinal cord. In the lower medulla, these fibers undergo decussation, the moment the vast majority of these nerve fibers cross over to the opposite side of the brainstem. The upper motor neuron completes its journey by traveling down the lateral funiculus of the spinal cord to meet its target. This anatomical crossing dictates the logic of clinical localization. Because of this switch, brain damage paralyzes the opposite side of the body, while spinal or nerve damage paralyzes the same side. The second half of the motor relay is the lower motor neuron, or LMN, often called the final common pathway. The LMN axon exits the spinal cord via the ventral root and travels directly to physically innervate the skeletal muscle fibers. This connection forms the spinal reflex arc, an automatic, localized loop that maintains baseline muscle tension without requiring input from the brain. This peripheral position makes the lower motor neuron vulnerable. When a localized nerve is severed or crushed, the physical link to the muscle is lost. An LMN injury entirely disconnects the muscle from the nervous system, which immediately drops the local reflex arc to zero. This reveals the core deductive rule. If the upper motor neuron is damaged, the muscle loses regulation but retains its reflex arc. If the lower motor neuron is damaged, the muscle loses both. The clinical examination begins with the assessment of muscle nutrition and bulk. Before touching the patient, the clinician visually scans for wasting, asymmetry, or abnormal hypertrophy. This healthy hand provides the visual baseline. Note the full, rounded contours between the metacarpals and the normal skin tension. By contrast, severe muscle wasting physically flattens the muscle architecture. The loss of lower motor neuron trophic support results in distinct concavities and skeletal prominence. When visual inspection is ambiguous, clinicians use tape measurements at specific anatomical landmarks, such as the acromion, olecranon, and tibial tuberosity, to quantify bulk. These measurements are always performed bilaterally, comparing corresponding muscle groups across the dominant and non-dominant sides. The clinician also carefully looks for fasciculations, spontaneous isolated motor unit firings that appear as ripples under the skin. These twitches specifically indicate a dying or irritated lower motor neuron desperately attempting to fire. Observing muscle bulk allows a clinician to read the historical record of a patient's peripheral nerve health over months or years. The examination continues with muscle tone, defined as the baseline resistance a relaxed muscle offers to passive stretch. To test tone, the patient must be completely limp while the clinician rapidly manipulates their joints. A sudden drop in resistance, or hypotonia, points directly to a destroyed reflex arc in a lower motor neuron lesion. Conversely, abnormally high resistance means the central nervous system's regulatory pathways are failing to inhibit reflexes. To diagnose the specific type of brain lesion, we look at velocity dependence, how resistance changes relative to the speed of movement. Spasticity is a specific sign of an upper motor neuron lesion. Moving the limb faster causes resistance to build exponentially until it suddenly gives way, much like a clasp knife. Contrast this with rigidity, a sign of basal ganglia dysfunction. Here, resistance is uniformly stiff and independent of speed, appearing like a bending lead pipe. Feeling a joint's resistance to speed allows a clinician to physically differentiate a cortical stroke from Parkinson's disease. The final stage of the motor exam focuses on power. This is the direct stress test of the neuromuscular junction and the contractile tissue itself. Power is tested systematically using isometric contraction. The patient holds a joint's posture while the clinician attempts to break their hold. The Medical Research Council, or MRC scale, is the standard objective language for quantifying muscle weakness. Grade 0 represents total paralysis. There is no visible or palpable active contraction. Grade 1 is a faint flicker, a visible contraction lacking force to move the joint. Grade 2 is the gravity threshold, where the muscle moves the limb only if positioned to eliminate gravity's pull. Grade 3 is anti-gravity power. The muscle moves against gravity but collapses under active resistance. Grade 4 indicates submaximal power, moving against gravity and some resistance, but demonstrably weaker. Grade 5 is normal power. The patient locks the joint, and the clinician cannot overcome the muscle force. The clinician must test systematically, starting with proximal joints like the shoulders and hips, then moving down to distal joints like the fingers and toes. These numbers reveal specific patterns. Peripheral neuropathies typically cause distal weakness, while myopathies result in proximal weakness. Isolated data points, like a weak grip or a stiff knee, are only useful when synthesized into a coherent neurological pattern. This diagnostic matrix combines bulk, tone, and power with deep tendon reflexes to create a definitive map. Because the final wire is cut, the LMN signature is defined by absolute loss, marked atrophy, fasciculations, flaccid hypotonia, and absent reflexes. Because cortical inhibition is lost, but the local reflex arc remains, the UMN signature is defined by chaotic hyperexcitability, minimal atrophy, spastic hypertonia, and exaggerated reflexes. A motor exam is not mere paperwork. It is the clinician's ability to trace an invisible lesion deep within the nervous system, using only their hands and systematic logical deduction.